Thanks for covering that. Well, certainly part of prognostic, but not predictive, as you stated. Okay, moving along into the starter net study, where we are looking at Lanreotide with Everolimus versus Everolimus in non-functional unresectable metastatic neuroendocrine tumor. Alok, your thoughts here?
Yeah, so this is a large phase 3 study of Everolimus plus Lanreotide versus Everolimus alone. And this was for gastroenteropancreatic neuroendocrine tumors. And these were grade 1 and 2. This grading systems, this is a tough one because, first of all, they keeps changing the nomenclature all the time. And this group in the middle, the grade 2, we don't always quite know what to do with them. Grade 3 is easy because they do really poorly. Grade 1 is easy because they do really well. But this did include both grade 1 and 2 according to the WHO classification. So the Ki-67, if you're following, is in the range of 5 to 20%. In some scales, it's between 3 and 20%. They did weirdly include less than 5% in this population if they had really bad liver disease. So heavy burden was also included on top of just the Ki-67. This was a first-line study, so no prior treatment for metastatic or recurrent disease, good performance status, adult patients, and about 250 patients or so. These patients are randomized to receiving either Everolimus daily with the usual dose of 10 milligrams once a day, or Everolimus plus Lanreotide. Again, study endpoints here were PFS, with OS being a secondary endpoint, which I sympathize with because OS is very prolonged in this population, so you kind of want to target PFS. But unlike colorectal cancer and some other cancers like breast cancer, where PFS is a pretty decent surrogate for overall survival, we don't actually know that for the neuroendocrine tumor population. So that's sort of a leap of faith here, especially because we know a lot of these grade 1 patients can do well for years. I mean, this is a population for a while. We were even doing watch and wait without any treatment whatsoever. You see here 1-year survival not substantially different, 97% versus 96.2% for Everolimus versus Everolimus Lanreotide. You pick out some of these subgroups, the diffuse liver metastases specifically with less than 5% Ki-67, not really significant there either. But again, you're talking really tiny number of patients probably in that specific subgroup, less than 50 patients, I think. And again, we are looking at PFS now for these subgroup analyses, not OS. The two subgroups where something did stand out are the two on the right, which is the Ki-67 less than 10%, 11 months versus 23 months. So that's sort of a substantial difference. And then the more than 10% Ki-67, also substantial difference, 11 versus close to 30 months. I think I'm gonna sort of reserve judgment on this one. I think a lot of neuroendocrine tumors is case by case, and they've tried to get to that here with this sort of diffuse liver mets, but less than 5% Ki-67. I think you have to take the whole picture into account. Was somebody just have diffuse liver mets because they were undiagnosed for years and years and years? Or did they have no symptoms last year and now they're presenting with a bunch of symptoms and therefore their liver is full of mets? There's a lot of nuance in the neuroendocrine tumor population, with the PFS being the endpoint, with all of these being sort of subgroup analyses. I'm reluctant to make a big practice change based on this.
Absolutely. And another thing to point out here is that Lanreotide as a single agent ends up being an option for a majority of these patients in our clinic today. And we did not see that as a control arm in that study. Yes, the combination of Lanreotide with Everolimus improved PFS. And Alok, you touched on this as well. There's no overall survival difference. I'm on the same bandwagon. I'm not willing to change my practice just based on this data right now.